Hey guys, can you see me and hear me? Hello guys, am I audible? Am I visible? Good evening, Shivkumar. Hope I am audible and visible. If so, let me know and let's start without any delay. Hello guys, am I audible? Am I visible? Okay, good evening, Alvito. Good evening, Shiva. So let's start. So I'm going to have a very short discussion on few questions. I hope you guys must have completed the first chapter. So the questions will be on the first chapter. Let's revisit everything quickly. So let's do this for after every RRR or the Nischay batch once it's over. We'll do that so that it's a revision for you. At the same time, you'll also get prepared for the NEET PG next exam, whatever it is. Fine. Kumar, unfortunately, Apoptosis knows I've deleted. I'll try to get it. If I get it, I'll definitely send it across. Fine. Okay. Read the question. I'll keep quiet for maybe 30 seconds to 45 seconds. Read the question very carefully and tell me what's the answer. And let's discuss a little bit about that question. Fine. So let's start. I'll go mute for a few seconds. Good evening, Pallu. Good evening, Savita. So what's the answer, guys? Whatever comes to your mind. Right, wrong, maybe. Okay, Kumar has gone with C. Savita has gone with C. Okay, let's read the question and let's see if you are right or wrong. Fine. Unknown to the world, B. Rishikesh Sirtuins. Fine. So red wine touts, they are contributing to the longevity, but this wine also controls the dietary control, everything, all those things with body mass less than 22, right? So the question is very simple. Which of the following intracellular substances will mediate the effect of calorie restriction upon increase the longevity, right? So the question is very, very simple. They are indirectly asking what is the way or how does red wine contribute to longevity of a person, right? You guys are exactly right. So see, few of them have answered D, right? So can anyone tell me, can red wine alter telomerase? Shivkumar as well as unknown to the world. It cannot do it, right? So the question is about red wine. So red wine per se is not going to alter telomerase, but yes, you are right. Telomerase enzyme will increase the longevity of a person or longevity of a cell with respect to your tumor cells, stem cells, or your germ cells, right? It will not be for every other cell. Only for these cells, yes, they do play a role in the longevity, but not for others, right? So undoubtedly, red wine is going to be into Sirtuin. Assalamu alaikum. Fine. So it's about Sirtuin in the red wine, which is going to relate to longevity, right? Just a follow-up question, if you guys can answer. I had told that red wine plays a major role in kind of having a genetic modification. They do a gene modification. Can anyone tell me what is the function of an active compound or what enzyme is the Sirtuin? There's an enzyme we're told which actually does the gene modifications, which is kind of anti-aging, which is kind of reduces the risk of diabetes, cancer, and everything. What's a gene modification does? Red wine is a component called as an NADP, NAD dependent deacetylase. Right? They are deacetylases, so they will inactivate the active gene component by reversing the acetylation. That's how the red wine imparts this effect of having longevity, right? Few more questions with regards to Sirtuin. Say yes or no. That's all. That's more than enough for me. So Sirtuin reduces the risk of your cardiovascular disease. Yes or no? Maybe. Whatever comes to your mind. Sirtuin reduces the risk of cardiovascular disease. Perfect. It's yes, right? Sirtuin increases the risk of cancer. Yes or no? Sirtuin? No, it does not increase the risk of cancer. It again reduces the risk of cancer. Sirtuin reduces the risk of diabetes mellitus. Yes or no? Sirtuin diabetes? Yes, they do reduce the risk of diabetes mellitus, right? So when I say longevity is there, so automatically all these lifestyle age dependent changes, automatically the risk will be reduced, be it diabetes, coronary artery disease, atherosclerosis, cancer, and everything, right? Perfect. Let's go to the next question. Read the question carefully and tell me what's the answer. There are just 4 options. Whatever comes to your mind, tell me. That's more than enough. This exercise is not to get the right answer. This exercise is to participate. Albito starts with B. The pathologist is examining the biopsy of an individual's left ventricular myocardium and notices that myocardiac myocytes are enlarged, right? The question is, which of the following conditions would best explain the enlarged cardiac myocyte, right? Okay, there's 2 things. Bengal Medico has told C and quite a few of you have answered B, right? First, let me ask a question, then we'll go to the options. Cardiac myocytes being enlarged. Tell me, what cellular adaptation are we talking about? Is it hypertrophy? Is it hyperplasia? Is it your metaplasia, or is it atrophy? What cellular adaptation are we talking about here? It is simple hypertrophy, right? Because one thing easy to say, my cardiac myocytes will not divide. The only adaptation they can undergo is hypertrophy, right? So if I rephrase the question, it's very simple. Cardiac hypertrophy, which of the following is the right answer, right? Now, can I say pulmonary hypertension can also cause cardiac hypertrophy? Yes or no? Just an yes or no answer. Pulmonary hypertension, can it cause cardiac hypertrophy? Undoubtedly, yes, it can cause cardiac hypertrophy, right? So, can anyone tell me why then the answer is systemic hypertension? That also can cause, but why is systemic hypertension the answer and not pulmonary hypertension? What made you answer B? What made you answer B? Perfect. This is going to cause the left ventricle, right? So here every statement is important for us, right? If you have just read cardiac myocytes and you're not included the left ventricle into the thing, then your answer will be wrong, right? Now, if I change this into right ventricle, what will be the answer? If the question is changed, because it's not like your UG exam, I will ask the same question what is there in the book. I can change any permutation combination, right? If the question is right ventricle, the answer would be pulmonary hypertension, right? It automatically changes. We can easily change tiny changes will definitely make an impact in the final answer, right? Perfect. You're absolutely right. Left ventricle involved, hypertrophy of the cardiac myocytes. One of the classical finding is systemic hypertension. That's all, right? The answer is option B. Everyone is right. Some of you answered option C. See, ventricular septal defect, they might cause an hypertrophy, but this also can cause hypertrophy. I'm not denying that. Now tell me, ventricular septal defect is a congenital malformation, right? Hypertension is not a congenital malformation, it's an acquired disease. Of these two, which you think is common? Which you think is common, hypertension or ventricular septal defect? Everyone will definitely answer hypertension, right? Ventricular septal defect is not that common, right? So whenever you have an option where both can look as a right answer, you might encounter this when you come to NEET PG. There are multiple questions where the 2 options look very close. That time go with the commonality. Definitely hypertension is way more common than ventricular septal defect. So I obviously will think of an hypertension as the answer, right? Perfect. Let's go to the next question. Read the question carefully. Tell me the answer, whatever comes to your mind. Then let's dissect it one by one the same way what we did for the previous question. Answers, it's a big question, doesn't matter. Okay, Kumar has gone with D. D, thank you, Running Bronco. D. Why you left A, B, and C? Some of you can contribute to A, B, and C. Okay, Lalit has contributed to A, Alvino to D. Okay, let's see one by one here, right? Okay, it's a 90-year-old person, severe dementia, been bedridden for 5 years, right? So some person is not moving for 5 years. Physical examination, there's no ulcer. Decubitus ulcer means if a person is not moving and slide down, right? Is there a possibility of bed sores? Decubitus means in the most dependent part, that's all. In the back, in the legs, in the buttock area. All the dependent parts you can have an ulcer. This patient does not have an ulcer. Let's exclude that. In buttock or lower extremities, there's no ulcer here. However, the upper and lower extremities are reduced in circumference, right? So can I say if a person is bedridden for 5 years, the person will not move the limbs? Yes. So reduction in the circumference of an structure or an organ. Again, what? Cellular adaptation. Hypertrophy, hyperplasia, metaplasia, atrophy. What are we talking about here? Same. See, whenever something is there, we have to definitely low down into the lowest way possible. So if we kind of make sense, if we kind of break the question, it's very, very simple to solve any question. It's undoubtedly atrophy. It's a disused atrophy to be exact. Fine. Let's read the question further. The lower extremity is more than the upper extremities with apparent significant loss of the muscle mass. Fine. Which of the following combinations of molecular mediators is most responsible for atrophy? So indirectly the question is asking which of the following is the mechanism of atrophy? Option A. Where did we read option A? Cyclooxygenase, thromboxane A2. Atrophy or inflammation? These are arachidonic acid metabolites, right? Thromboxane A2, cyclooxygenase. Maybe thromboxane A2 could be for your clotting cascade as well to some extent, right? So these are arachidonic acid metabolites. It has no role in atrophy, right? Kind of gone, right? Again, 12 lipoxygenase, lipoxin A4. Can I also say this also is inflammation? Undoubtedly, right? So this also comes in inflammation. This leukotriene B4 comes from A4, the chemotactic mediators, right? P53 and BAX. Where have you heard BAX? Where have you heard BAX? BAX, BAC, BCL2, everything. We have heard them in apoptosis, right? So we have read this in apoptosis. So that also is most likely the not the right answer, right? I'll come to this option very soon, right? Ubiquitin proteasome pathway. Can I say that we did read this in atrophy? Right? So older proteins will have an ubiquitin tag and the proteasome will kind of destroy them, right? The ubiquitin proteasome pathway is undoubtedly the direct one for atrophy. It's a mechanism of action of, okay, I'll come to a neat UG scroller, right? So now we did read two things in atrophy. One is ubiquitin proteasome pathway. Can I also say if option D is autophagy, will that also be the right answer? Is that right? Right? Obviously right, right? Now, I'm going to ask you one more different question. Let's answer that and then let's discuss what is the problem here. Fine. Can atrophy be irreversible? Yes or no? We did read about 4 cellular adaptations and in that I said particularly atrophy is something which can be irreversible as well, right? You're right, Bengal Medico. It can be irreversible as well, right? So when we did talk about irreversible atrophy, like uterine atrophy, endometrium will not come back, right? We lost thyroglossal tract, it will not come back. Thymus will not come back. So atrophy can be both reversible and irreversible based on the stimulus. So I did tell that irreversible atrophy, what's the mechanism? This is for reversible atrophy. Autophagy and for ubiquitin proteasome pathway, it's a reversible atrophy, right? Irreversible, what do you think will be the mechanism of action? Irreversible atrophy is always by apoptosis, right? So if it's an irreversible atrophy, it's equivalent to apoptosis because it's cell death. A cell death will not come back, right? Perfect. Now I'm just going to change the question a little bit, right? A 55-year-old person, the entire uterine endometrium, the thickness have reduced a lot, become very thin. What could be the mechanism of action? 55-year-old postmenopausal. What do you think is the mechanism of action? Their apoptosis or ubiquitin proteasome pathway? Postmenopausal endometrium will not come back. It's an irreversible change. It's apoptosis. Now I had the same question saying that in a developing fetus from a child, the thyroglossal tract has disappeared. That is an example of atrophy. I'm not denying that, right? But the mechanism microscopically will be apoptosis, right? So whenever you're talking about atrophy, see whether I'm talking about an irreversible change or a reversible change. If the question is protein energy malnutrition, reversible change. Obviously this patient, if I'm going to start giving physiotherapy, it will slowly regain it, right? It will not do it in a day or two, but it'll slowly definitely regain it, right? So please do read, or if it's a question on atrophy, if it's a reversible atrophy, ubiquitin proteasome pathway or autophagy. If it's an irreversible atrophy, think of apoptosis, right? Okay, next question. Read the question carefully and tell me what's the right answer. Everyone online, comment. It's fine to make a mistake. Whatever comes to your mind. Alvito's gone with C. Others, Kamran C, Kumar C. Okay, Tisha C. Good. So see, it's a useless 5-line question. Most of the 5-line questions what you encounter in NEET PG will be like this. Not I have to add few more things to extrapolate, right? Exactly what you did in your anatomy paper. That's what they primarily do, right? Make it bigger. That's all. Fine. Perfect. So now the question is simple. Scientist conducts an examination experiment using lipofuscin as a substrate. It's lipofuscin. When you know lipofuscin, obviously you know it's an wear and tear effect. It's an pigment of cells aging. That's all, right? So obviously 15, 40, 75, my option is going to be by default liver, right? By default, liver will be the option. If at all I have to make this question a little bit difficult because it's a very, very simple question, all of you have answered, right? Now let's say I made it 75-year-old pancreas, heart from a 75-year-old, liver from a 75-year-old. What will be the answer? Liver, heart, pancreas from a 75-year-old person. What will be the most likely answer? Where do you think lipofuscin can maximum accumulate? 3 organs: heart, liver, pancreas. Heart, liver, or pancreas? Heart, right? So this might not come because it's irrelevant in a current clinical scenario. Heart is more than liver, then pancreas. This is the order by which most of the lipofuscin accumulates. These are the major organs also where lipofuscin will accumulate, right? Heart, because it's a constantly functional tissue and there's no regeneration there, so automatically the older cells keep on recirculating, so you'll have a good amount of lipofuscin. Liver, because of metabolism and every toxin we take goes to the liver and causes damage, so ages faster. Pancreas, because of food. You take food, more and more and more activation of both exocrine and endocrine pancreas, so it results in lots of lipofuscin accumulation, right? If at all, if I have to ask the same age, this will be the sequence of the best answer: heart, next liver, next pancreas. Fine. Okay, next question. Whatever comes to your mind. But do make an attempt. What's the answer? Okay, Bengal Medico, Sunny has gone with option C. Shiva has gone with A. Kamran C. Trisha A. Okay. See, this is an indirect question. It's actually a factual question. I have just made it a big line, 3-4 line question. That's all. The question is indirectly asking which of the following is the most potent free radicals species. That's all. Or reactive oxygen species. Which is the most potent? Okay, Kamran, I'll come to it soon. Which is the most potent? The most potent reactive oxygen species undoubtedly is OH minus. Fine. OH minus has the highest propensity to cause protein changes, intracellular damage, DNA damage, be it in cell membrane damage, always OH minus, hydroxyl free radical, right? Now, Kamran has told us HOCl. So, Kamran and everyone here, HOCl is most effective against human cells, or HOCl is more effective against bacterial cells? Human or bacterial? It's against bacteria, right? It's extremely bactericidal. It's not against human beings. It's extremely, extremely bactericidal. So do remember that, right? So if the question is on a cultured human cell, the most effective one is by default OH minus, hydroxyl free radical. If the question is on inflammation and bactericidal, obviously HOCl is the most appropriate answer, right? Again, all the answers will be subject to change to question whatever we see, right? Bleaching powder is the best example. Hypochlorous acid will be used day to day in your hospitals. Go to your ward, they'll have hypochlorous acid. Urine falls, blood spills, any body fluid spills on the floor, they'll pour that and close and keep. Fine. Okay, read the question and let's see how many of you can give the right answer. Hey, sorry guys, sorry. I hope you can hear me. Fine, ignore that. So good, all of you have answered. The variation is more important so that we can learn more. I hope you can hear me, right? Okay, perfect. So now let's read the question one by one. Okay, you can hear me, right? I hope you can. Fine. I muted for the options. Fine. So this husband of a 62-year-old female found unresponsive on the couch and in the apartment when he returned from the work, right? So in other words, I'm having an elderly person who's dead, okay, and came to the hospital and they are pronounced dead. Fine. An autopsy revealed a well demarcated wedge-shaped yellow lesion in the cortex of the left kidney. Okay, let's make a scene for it. Then we'll go to the what exactly we are looking at, right? A person who's dead, unresponsive. What could be the most likely cause? Let's look at this first and then let's come to the rest. Just like that, the person is dead. Most likely cause in an elderly person who dies, we'll always think of an heart attack or a stroke. These are the common causes which can cause sudden death in any person. A massive stroke or a massive MI, both of them can definitely cause a sudden death, right? So again, I'm suspecting most probably a massive MI. I'll come to the Sogata, or a stroke, right? These are two possible reasons of the death in this person, right? Now let's come to the wedge-shaped lesion in the left cortex of the kidney, right? Sogata, it's not only in spleen. The reason for wedge shape is, let's assume I'm having an organ like this, be it a kidney or be it a spleen, whatever it is, fine. Okay, we are having an organ, and let's say I'm having a blood supply here. Okay, let's assume this is a blood supply. Fine. This blood supply here has been blocked by something. Something is blocked. So can I say whatever region this blood vessel supplies will die, and that region will always be in the form of a wedge. That's how death will be. Not exactly like a wedge, but it will be a very demarcated area, because a blood supply, a blood vessel goes, it bifurcates like this. In most of the organ, the blood vessel goes and bifurcates like this. That's how it will be, and that's why we have a wedge-shaped infarct. Whenever we have something in wedge-shaped whitish or a yellowish color, we call it an infarct, right? A wedge-shaped infarct, most likely it is due to a thrombus. Infarct is almost always due to a thrombus, which has come from any other source, right? Now let's go to the option. A Mycobacterium tuberculosis infection, can it cause an yellow color discoloration? Yes or no? Mycobacterium tuberculosis of the kidney, can it cause a yellow color discoloration? Absolutely yes, it can cause, right? But for having a Mycobacterium tuberculosis, why should the patient die just like that? Might have cough, fever, loss of weight, symptoms due to the kidney. So the presentation is not fitting into it. One. Second, why should I have a very well-shaped demarcated region? So this is not the right answer, right? Renal cell carcinoma again might be yellow in color, might not be well defined, because carcinoma is always ill-defined, and carcinoma patient again need not die unresponsibly, right? Metastatic colonic adenocarcinoma, again, why death immediately? And there's no symptom at all. Colonic adenocarcinoma will have definitely symptoms, and then metastasis might be there but will not be immediate death, right? This is the most appropriate answer considering this patient had an MI or a stroke. So which means by default I can say this patient's blood vessels are already narrowed. There's a possibility. Now let's assume the patient has an MI. Can I say you can have arrhythmias in MI? You can have. Can arrhythmias cause an embolus? Arrhythmias are very irregular pumping of an heart or beating of an heart for the fresh second year student. So this can cause an embolus from the MI, and the embolus can definitely go and block the artery, right? That's the most probable answer here. Might be due to vascular phenomenon. It has gone and blocked the kidney and I am having an infarct in the kidney, right? You're right. Option is answer D, and we also learned why the other three are not the right answer, right? Okay, next question. Read the question carefully and then let's discuss. I'll move a little bit so that you can see the image as well. It's a tricky question. Let's see how many of you get the right answer. Okay, Bengal Medical started the thing with A. Okay, Sunny has gone with D, Reshmi has gone with A. Others, come on, comment. It's fine. It's fine to make a mistake here. We'll learn from the mistake undoubtedly. I'm telling you, if you make a right answer, you won't learn. If you make a wrong answer, you'll definitely learn. Okay, let's read the question and then let's look at the image and let's come to the options. A 59-year-old person, alcoholic, brought to the emergency room with fever and foul-smelling breath, right? So this is an important history. We'll see why. The patient subsequently developed acute bronchopneumonia, which is an infection of the lung, and dies due to respiratory failure. And a pulmonary abscess is identified on autopsy, right? I'll just move it here. This structure here is the abscess. Okay, you can see a very well-defined area. Most likely this should be a pus. So I have a pus-filled, well-defined area in the lung, abscess, right? Now, why alcoholic is important is, have you seen people lying down on the floor vomiting in alcoholics? Completely full of alcohol, they'll eat a lot and they'll vomit. So when an alcoholic vomits, the problem is something might enter into the trachea, regurgitation. Aspiration can happen by default. So when I aspirate a food substance, can it go and deposit in the lung and cause an infection? It can. That's why alcoholic is an important history for me to explain a lung abscess. Abscess is pus filled. Will the pus be of foul smelling? Obviously, right? So even if I don't give the diagnosis of abscess here, you should have made the right answer. So it's a classical case of an aspiration pneumonia with a lung abscess, right? Now I'll rephrase the question. Most of you answered A because for you, lung means tuberculosis. That's all, right? It's an immediate response. Is this TB abscess or is it random mixed bacteria related abscess? It's not a tuberculous abscess, right? Tuberculous abscess will not be an acute bronchopneumonia. Tuberculosis can cause abscess, but it will be a long-standing history, right? So it's a mixed bacterial abscess, and tuberculosis will not have a foul-smelling breath, right? So now tell me, if I remove every image here, if I remove every history, what is the type of necrosis in an abscess? Coagulative, caseous, liquefactive fat. The type of necrosis in abscess undoubtedly is liquefactive, because in any abscess cavity, you will have excess amount of WBCs. WBCs by default will have lots and lots of enzymes, and enzymes will be released. Always enzymatic necrosis, liquefactive necrosis, right? So please don't get deviated just because I'm having a lung lesion. Lung is not always equal to tuberculosis. It should fit into the history. So it's a lung abscess. That's also given in the question. The best answer here will be liquefactive necrosis and not caseous necrosis. Clear? So everyone who answered A, think a little bit different. Read the question. It should fit everything. Fine. Perfect. Read the question. Let's see if you can tell the correct answer. Make an attempt. Many of you are online. Don't be silent observers. If you're not able to put the name in your name, comment in your name, keep random name. No one cares. No one will remember you if you make a mistake here. A, B, C or D. Again, whatever comes to your mind. No one is ready to take a chance. Okay, Sunny has gone with B, Kamran has gone with D, Albino D, Gayatri D. Let's see, let's read. So it's a patient who's a poorly controlled diabetic mellitus. So you have a glucose of 576. When you go to forensic medicine, you will see why did we take vitreous humor, vitreous lesion for chemical assessment in a dead patient, fine? Okay. Microscopic examination of the kidney shows clear vacuoles in the renal tubular epithelial cell, right? One thing I have told you, whenever it's clear, think of fat. But whoever answered B, how did fat come into kidney? Very unlikely, right? I'm having a patient who's diabetic. It's not normal, extremely uncontrolled diabetes, 576. So can I say the renal tubules would have reabsorbed sugar? Lots, right? Definitely, right? The tubules of the kidney would have definitely had lots and lots and lots of sugar or glucose reabsorption. So when glucose is reabsorbed in lots of quantity, right? Very high quantity, can it convert to glycogen? It can, right? So this glycogen will be deposited in the kidney, right? So this is also will also be clear. I told you glycogen can have two colors, pink or clear, based on the amount or the density of glycogen. That's how it is, right? Glycogen can be both pink as well as glycogen can be clear as well. Here I'm having excess of glycogen, so it gives the appearance clear, right? So this is glycogen, not fat. Hemosiderin will not be a differential diagnosis, will not be clear. Lipofuscin again will not be clear, right? So these are the glycogen accumulations in a person who has excess of diabetes, and this has a name called as an Armani-Epstein lesion. Okay, these are Armani-Epstein lesion is nothing but glycogen in the proximal convergent tubules in patients with uncontrolled diabetes. Just an extra term. This might not be useful now. Maybe in the latter half of your second year, when you go to exams, it might come handy, right? Armani-Epstein lesion, also a finding of diabetic kidney. Okay, next question. Tell me what's your answer. It's a simple question. We won't discuss much about this. What's your answer? Simple, right? It's a classical of fingers and toes formation, removal of tissue, a classical example of physiological apoptosis. Physiological apoptosis, and the question says, which is most likely to block apoptosis, which means I'm talking about an anti-apoptotic gene. Undoubtedly, the answer will be BCL2, right? Physiological apoptosis history, and what blocks apoptosis or an anti-apoptotic gene is option B, BCL2, right? I'm not going to the rest of it. This two are cancer related, and this is not a proper gene. Fine, perfect, great. Next question. Again, it's a very simple question. Let's see if you can pick up the right answer. Most of the patients are dead. That's the only way I get a biopsy. Okay, come right and start with A. Anyone else? Anthracosis. A. Okay, let's read the question. 65-year-old person suffers from heart attack and expires. Examination of the lung autopsy shows numerous pigmented nodules scattered through the lung. All these are black. Something black in color in my body. The first and the only diagnosis which I want you to think of is coal. Right? Can anyone tell me anything else which can be black in color? Coal undoubtedly is black. Anything else which can be black in color? I told this in a liver biopsy. Think of a condition called as Dubin-Johnson syndrome. Dubin-Johnson syndrome in liver biopsy can also be black in color. Melanin in microscopy is brown, not black. In liver, a type of a congenital jaundice, I can have black spots, right? One more thing, you can have black color pigments in your joints, in your ear cartilage. Can anyone tell me the diagnosis? You think of alkaptonuria. Okay, alkaptonuria also can have black pigments. Again, a very rare finding, but you can see the blackish discoloration in the gross as well. Microscopy also has little bit of brown black pigments, right? But first, undoubtedly it's coal, and none of this will form black pigments in the lung, right? And this is a classical finding seen in lung. Lung has only one black pigment, and it's undoubtedly anthracosis, and that's a disease which is it's termed as coal-induced lung. Your lung, my lung also will be black in color, will have anthracotic pigments by default, fine? Okay, next question. It's visible. What's the right answer? Again, this I won't discuss much. You should not miss this question, right? There are few questions. If you make a wrong answer, it's not good. That's one such as this. Okay. Chest X-ray of a person, 37-year-old, 3 centimeter nodule in the middle of the right lung, shows a sharply circumscribed soft mass with white center. This is how grossly you'll have granuloma. Okay, and serum interferon gamma assay is positive. Again, We in the Nischay batch we did read about chronic inflammation in the last class. Interferon gamma is one of the most important thing which is involved in the granuloma formation, and that we use for diagnosis as well, right? So there's a test called as quantiferon gold. Quantiferon is quantitative interferon assay. That's quantiferon, right? Quantiferon gold assay is a test which will assess interferon in the person's blood, indirectly saying, okay, the patient is having the granuloma formation, right? In addition to this, can anyone tell me what this is? There's a classical finding in the image. What is that? What is that? That's your perfect. That's your Langhans type of giant cell, which also kind of suggests me it's a tuberculosis, right? All points out to only one guy, which is tuberculosis, and TB is only one necrosis you're worried about, which is caseous necrosis, right? You're absolutely right. The Langhans type of giant cell pointing to TB diagnosis. Perfect. Okay. Next question. Read the question carefully and tell me the answer. This could be a tricky one. So read carefully and tell the answer. What's the answer? Okay, Kamran has gone with C. Others? Say an A, B, C, D. That's an amazing one, right? I hope every exam gives you option like that. Kamran has changed the answer. Vinay has gone with D, C. Okay, let's read the question and let's see what will be the right answer. 11-year-old girl infected with hepatitis A virus experiences mild nausea for 1 week. Examination has right upper quadrant tenderness, scleral literacy. Lab finding shows an AST level of 68, ALT level of 75, and bilirubin of 5.1. Right? All these three are elevated. Right? Her lab findings is most likely due to the result of what are the changes in your hepatocyte. Right? Okay. Now we did read about necrosis and apoptosis. Here, when we read about necrosis and apoptosis, I must have told this for sure. Which of these two will have cell membrane damage? Undoubtedly necrosis, right? So a patient with necrosis undoubtedly will have cell membrane damage. So the cell membrane is damaged. Did we read that all the intracellular contents will come outside? They will, right? All the intracellular contents in necrosis will leak outside. That's why we use your troponin I, troponin T in case of a myocardial infarction, CKMB, creatine kinase in case of a muscle damage, liver, all the biochemical tests is based on this, right? Because the cell dies, cell membrane dies, intracellular content leaks, right? So now the question is particularly asking, what's the reason for the lab findings? Which means what is the reason for the elevated AST and ALT? That's all. Elevated AST and ALT, the only reason here is your intracellular content leak and necrosis. And here in necrosis, option A is the right answer for this. Great, Sehan. Mitochondrial swelling might happen, nuclear clumping might happen in necrosis, but that does not cause elevation of the blood enzyme levels, right? So blood enzyme is being elevated, all blood tests is being elevated. The only answer for that is cell membrane damage, right? If I have a question of MI here, and I say that in patient with MI, there's elevated troponin T or troponin I, the same answer. I can ask different thing. I can put any different scenario. If there's an elevation in the blood levels, it is due to cell membrane damage only. Okay, don't forget that. Okay, perfect. Next question. Something which we didn't read. It's not a part of your curriculum, but we'll still discuss that. There's a table in Robbins just to have a quick look into the table. What do you think is the right answer? Take a random guess. The explorer guy, it might not cause fulminant hepatitis, but again, can COVID cause death? The answer is yes. How many percent of COVID? 1% of COVID. So anything can happen in any disease, right? Normally hepatitis A is very, very subtle, so might not cause a fulminant hepatitis. Doesn't mean that it will not elevate liver enzymes. It will elevate liver enzymes. It will damage, but it will still elevate liver enzymes. Fine. Okay. Perfect, guys. So just the following are examples of protein misfolding defect. Answer is obviously cystic fibrosis. There's a table in Robbins All these are the protein misfolding defects, right? So cystic fibrosis, where CFTR is an altered protein, I have a problem in the receptor, so it's not functioning properly. Familial hypercholesterolemia, I must already know first year itself, LDL receptor. Tay-Sachs, this enzyme does not work. The reason why the enzyme is not working is it's an altered protein or a misfolded protein. Same with this enzyme will not work. Creutzfeldt-Jakob disease, this is a type of prions where I have misfolded prion protein, and Alzheimer's, we have an amyloid deposit that also is a misfolded protein, right? So we'll read all these diseases in different places in pathology, but I didn't cover this in the first chapter because it will be a little bit too much for us. It's fine. Prakash, आपका डाउट क्या है? You tell me your doubt and मैं अंग्रेजी से रिप्लाई करूँगा, ठीक है? हिंदी में फ्लो अच्छा नहीं है, इसलिए मैं अंग्रेजी से बोलूँगा, ठीक है? Fine. Yeah, those will not work here, Explorer guy. Okay. Okay. What's the answer? Next question. In acute tubular necrosis, yes, you will have coagulated nucleus salvator. I'll take your doubt, Kamran. Just give me a second. We'll complete this question and we'll go to doubt. It's a very simple question, right? The question is very clear. What's the reason for fatty liver in alcoholics? In alcoholics, this is the reason. Because alcohol, once it's metabolized, the dehydrogenase everything will give lots of NADH ratio. Because of that, the entire fat metabolism kind of goes bad, right? This also causes fatty liver. I'm not denying that, right? Option B causes fatty liver in patients with maybe an protein energy malnutrition, more fatty acid delivery from the periphery, or a patient who's consuming lots of fat, like a non-alcoholic, it can cause, right? But option A is the reason for this one, right? Previous question, okay. Dr. Prakash, these are groups of diseases which will have defects in protein folding. So when protein is not folded properly, the protein will not function properly. That's why we have these defects. So these are grouped as protein misfolding defects. That's all, Prakash. Okay. This question, Kamran, see, for me to call something as caseous necrosis, every necrosis first will be pink in color. Giant cell also will be pink in color because it's coming from an epithelial macrophages, which also will be pink in color, right? Right. So here I am not going to call it coagulative for two reasons. One, the pink color here is granular. I'm having lots of clear area in between. So when I think of a granular necrosis, I think of caseous predominantly. Normal coagulated necrosis will not have giant cells, will not have this elongated epithelial macrophages. Neither will have granuloma. So I'm having granuloma, giant cells, epithelial macrophages, granularity, mostly caseous necrosis. On top of that, TB. Why should I think of coagulated necrosis in TB, right? So it does not fit into coagulated necrosis. It's definitely undoubtedly caseous necrosis. Fine. Okay. Let's go to the last question. Let's see if you guys can answer. I'll answer it, Bengal. Just give me a second, Bengal. What do you think is the right answer? Guesses? Okay, I'll give you a clue. This is of accelerated aging. Okay, B. Okay, Kamran, I think exactly confused the opposite. So one thing here can I say this 15-year-old person is normal? Definitely. Till 15-year-old, the person is not having an accelerated aging, but 25 looks very old, 35 looks very old, 43 looks even old, right? So here the aging actually, the accelerated aging here actually starts little late, or in other words, it starts after puberty. So which of the accelerated aging disease will start after puberty? Hutchinson-Gilford progeria or your Werner syndrome, which will start after puberty. Because here the 15-year-old girl is completely normal. Girl or boy is completely normal. Right? It's the opposite. Lamin is also right. Lamin is the answer for progeria. Remember always to remember progeria. Remember the movie Pa. Pa, Amitabh was a school-going kid. He was very, very, very old, right? So progeria, the aging starts very, very early. Kamran, it's a reverse. Progeria kid will not live till 43, but maybe Werner's kid can live till 43, right? So here Werner, the answer is option A. In Werner syndrome is where the aging starts a little bit late. So do remember that, fine? Okay, remember that, fine? Okay, Bengal Medical, just will take a query. Where is that? That's option. See here, we'll look at this here. Can I say alcohol is undoubtedly a source of energy? Can we say that? It is definitely a source of energy, right? So more and more and more and more source of energy accumulates. That also will increase my NADH level. And same way the dehydrogenase also will increase the NADH level. When it accumulates in the liver, it kind of will trigger the fatty acid oxidation, fatty acid production. That increases the fatty liver, right? That is the reason why option A, excess NADH caused by production of the pyruvate lactate or caused by production of the dehydrogenases, the action of dehydrogenases will automatically increase the fat accumulation in the hepatocytes. Fine. Okay. Inhibition will not cause it. This will actually reduce it. This is also an action, but it's not for alcoholic liver disease. Okay, Bengal? Fine. Okay. That's all for today. See you in the next class. I don't know when is my next RRR. You enjoy the next week. Next week will be a week of Diwali. Enjoy it. All work, no play makes everyone a dull person. Enjoy. Let's come back again and let's definitely read the entire Robbins together slowly and steadily. Fine. If you know what the doubts, let's call it a day. Thank you guys. Thank you for your time.